Hello. So welcome again to the University of Alberta Child and Adolescent Psychiatry Grand Rounds. I'm Dr. Alice Liang, and I will be your moderator. We are very grateful to be partnered with our FOMD Office of Lifelong Learning, or L3, which provides much of the technical and logistical supports for these rounds. So we acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. So just as a reminder, please use the chat feature if you have a question about technical issues. And if you have a question for the speaker, use the Q&A feature of the webinar, and I think you can, upvote questions as well. Okay, so I would like to introduce our speaker. Marie Sidney is a speech and language pathologist with over 15 years experience with pediatric and adolescent speech, language, and literacy clients. And she has worked within a variety of settings, including private and public school boards, health centers, nonprofits, FSCD contracts, and private practice. Furthermore, Marie has received specialized training for pediatric and adolescent FASD, ASD, and social pragmatic communication disorders, and as well has participated in multidisciplinary assessments related to these disorders. She has extensive experience, both expertise, both experiential and academic, with assessment, goal setting, intervention, and consultation in all these areas. She believes in the importance of clinical education and has led several training sessions for staff, presentations for parents, and was a clinical educator in the Masters of Science, Speech and Language Pathology program at the University of Alberta, where she received a nomination for a Clinical Supervisor Award. She is currently the professional practice lead of rehabilitation services, as well as continue to provide clinical speech and language pathology services at Casa Mental Health. So I consider you one of our own. So I'm really enthused that you're able to talk with us today, Marie.
Thank you, Dr. Liang. I'm really happy to be here. I know that we have tried for about 1.5 years now to find a time to fit it into the schedule. All right, so the topic today is communication disorders in the DSM-5, but specifically a speech language pathology perspective on them. To briefly talk about disclosures, I didn't have anything to disclose today. I'm not receiving any supports of any kind, and there are no conflicts of interest I was able to identify. The DSM-5, as we know, is a manual used by psychologists and psychiatrists to diagnose and classify mental health disorders. Speech pathologists don't use that manual. That's not for our field. However, there are some similarities and some overlap between the things and disorders that we diagnose and what's in that section of the DSM. And there's a lot of differences as well. So this is essentially the topic for today, and I hope you can gain some perspective on how an SLP can be a valuable member of a multidisciplinary team that may use the DSM. And something that I'll talk about from time to time too is that the American Speech Language Hearing Association, or ASHA, whenever there is a revision to the DSM, so from the DSM-4 to the DSM-5, when they put out public opportunities for feedback, ASHA will submit feedback on behalf of speech pathology field, which is really interesting, and it kind of helps framework this a little bit for us. So I'll be bringing that up from time to time as well. First, I want to begin by just outlining a brief overview of speech language pathology, what we do, what we are. So speech pathologists are healthcare professionals with education and clinical training in assessment, treatment, and consulting on a variety of communication disorders in the following areas. So we have language delays and disorders, and then we further break that down into receptive, expressive, and pragmatic language, which I will get into a little bit later. Speech delays and disorders, which has to do with, so language has to do with the words, the language formulation, the message. Speech delays and disorders has to do with the individual sounds and producing those sounds. And that can be further broken down as well into articulation, phonology, and motor speech. Then there's voice and resonance disorders, fluency disorders. We work in pre-literacy and literacy skills, feeding and swallowing disorders, as well as supportive interventions. So supportive interventions are things like accent reduction or affirming voice gender work. Okay, so let's get into it. So here is a list of the communication disorders in the DSM-5. So we have language disorder, speech sound disorder, childhood onset fluency disorder, stuttering, social pragmatic communication disorder, and unspecified communication disorder. And let's see how that relates to the SLP field here. Language disorder does correspond to our category of language delays and disorders, pretty straightforward. Same with speech sound disorder. We have speech delays and disorders, and we have fluency disorders. Now, when it comes to social pragmatic communication disorder, I've put that arrow under language delays and disorders. So when we talk about that, when we get to that heading, we'll talk about that a bit more, but basically speech pathologists, for the most part, consider pragmatic language difficulties or social communication difficulties to be under this language delay and disorder heading. And then, oh, sorry, I'll just go back here. Unspecified communication disorder. I don't have an arrow or a box to draw that one to. We don't have a specific category in the same way that the DSM-5 does. However, we have some general terms that sometimes you'll see speech pathologists use. So we'll talk about that a little bit more as well. Okay. So that first communication disorder in the DSM is language disorder. Oh, and I should mention too that, you know, if I'm abbreviating DSM-5 text revision to DSM-5 or DSM, it's just to kind of get through my presentation and shorten things a little bit. But please know that I am speaking about the most recent edition of the DSM. And speech language pathology or speech language pathologist can be shortened to SLP as well. Okay, so language disorder in the DSM is described as persistent difficulties in the acquisition and use of language across modalities, spoken, written, etc. And that can include vocabulary, sentence structure, and discourse. It can involve deficits in either comprehension or production. And to get this diagnosis, you need language abilities that are substantially and quantifiably below age expectations. And it's not attributable to hearing, sensory, or motor difficulties, or another medical condition or intellectual disability. Okay, so now let's take a look at the language delays and disorders from the speech pathology perspective. We describe it in a very similar way. It's conditions affecting the use and understanding of verbal, nonverbal, and written communication. And we break it down into the receptive language, expressive language, and pragmatic language that I briefly touched on earlier. Receptive language is difficulties in understanding or comprehending what you hear. The DSM had mentioned comprehension in their definition as well. Expressive language difficulties would be difficulties in communicating a person's thoughts or needs in words and sentences. So this is more the output of language. And the DSM had described that as production. And then there's pragmatic language that we put under the same category. And that would be using language use in social situations. So knowing what to say, how to say, and when to say it. We consider that part of language use. Okay. Now, speech pathologists, like you'll notice the heading here is language delays and disorders, whereas the DSM, it's titled language disorder. They've got one term in there to use. There's a lot more variability and I'd say even inconsistency in the speech pathology field. So you will see SLPs using the word delay and disorder. And sometimes they're using those interchangeably, that they kind of mean the same, whether they call it a delay or disorder. And it differs from clinician to clinician, what terms specifically that they use. Some have their own system for when do I use a delay, when do I use a disorder. So it can cause a little bit of confusion in our field for how kind of all over the place it has been. But that being said, there has been some recent recommendations internationally within the last, I think 5 or 6 years or so. And that's been supported by the Canadian Speech Language and Audiology Canada and the American Speech Language Hearing Association, so SAC and ASHA, have supported this shift for SLP's terminology to be more consistent, to have more straightforward guidelines of when to use the word delay and when to use the word disorder. Right now, though, in the field, it hasn't completely caught on. So you will still see, if I go back, you'll still see delay and disorder kind of used in whatever way that clinician is using them. But hopefully as time goes on and these guidelines and recommendations, you'll see it in practice a little bit more, then our field will become a little bit more consistent and a little bit more in line with the DSM as well. But basically what they're recommending is that language delay is used for under 5 years of age. And one of the biggest reasons there is because the word itself, delay, really does imply that the child is going to catch up to their peers. And a lot of times they do, but sometimes they don't. Sometimes that these language difficulties they're experiencing in early developmental age persist onto middle childhood, adolescent, and even adult. So this way of categorizing it, of calling it a language delay when they're younger and a language disorder when they're older, is just a little bit more clear about what we're talking about. And we consider language disorders to be an umbrella term. So I've kind of organized it this way, which I know is helpful for myself. We've got the language delays and disorders heading at the top, and then we've got language delay and language disorders.
Yeah, sorry, Marie, we got a request for you to maximize your presentation screen. I'm not sure if you can put it into presentation mode.
Oh my gosh, I'm so sorry.
That's okay. Like you say, this is, yeah.
It must be, yeah, no, this definitely
so
is.
It's a little bit of a learning curve here.
The screen I'm looking at, it is maximized, but I think I shared the wrong screen. So I wonder if I can just switch which screen I'm sharing from. Is it okay if I stop sharing and reshare?
Yes, you can do
Okay.
that. That would be fabulous.
Okay, thank you for bringing that to my attention. See if I can.
The audience members actually did.
That is great. Thank you so much. I think it's this one. Is that better?
Yes.
Yes, that's perfect.
Oh, great.
Thank you.
Thank you. Thank you for your patience. I was actually thinking about it. I was so surprised that I've never given a webinar because during the pandemic, the last several years, so much has been online that I can't believe I've made it this far without without doing one. So learning lots today. All right. Okay, where was I? Okay, so I was just about to talk about how, so now there's this big push, this big recommendation in the SLP field to really specify when we use the terms language delay versus language disorders. And that language disorders is actually an umbrella term. So we have two categories that fall underneath that. We have developmental language disorder, or DLD for short, and language disorder associated with, and that would be a name of a condition where that condition is the main diagnosis, and that the language difficulties are kind of a symptom or a characteristic of that disorder. So these are biomedical conditions like genetic syndrome, hearing impairment, autism spectrum disorder, or intellectual disability, those types of things. And then developmental language disorder would be a language disorder, so an issue with language persisting on past early development, but with no known cause or no main diagnosis explaining it. And then when we're using the language delay term, it is recommended that we add this line here, this box that says at risk for developmental language disorder, so that we're identifying, we're letting the teams and the families know that, yes, your child might catch up, but they might persist, and they're too young to kind of know yet. Okay, and then there's even more recommendations that for using these sorts of terminologies. You saw earlier that SLPs always break down language difficulties into receptive, expressive, and pragmatic. So we haven't forgotten about that here. Whenever we are giving a language disorder diagnosis, either one of these two, DLD or language disorder associated with the condition, we then want to describe specifically what that looks like. So we would use the phrase, or it's recommended that we use the phrase characterized by, and then we list individually which ones are affected for that child. It could be one, it could be two, it could be all three. That really differs child to child. And then we get a very clear picture of what is going on with this child language-wise. So this is what it might actually look like for you if you're seeing it on an SLP report or coming across it some way. This is the recommended way to write these sorts of, or to use these sorts of terms. So the first example here is if a child is under 5. So let's say they were diagnosed with a severe receptive and expressive language delay, then we would also add at risk for developmental language disorder. An example of the DLD diagnosis might be developmental language disorder characterized by mild expressive language difficulties. And an example of the third category, language disorder associated with fetal alcohol spectrum disorder, characterized by moderate expressive language difficulties or moderate to severe pragmatic language difficulties. So this is kind of the recommended way going forward in our field, but like I said, it's going to take some time to settle and disperse and start being used in clinical practice. So you still might be seeing it used differently, delay and disorder in different ways. Okay, so let's compare. We talked about language disorders in the DSM-5. We talked about it in the speech pathology field. Similarities between them on the left-hand side here, the definition are very similar. There's agreement across both fields there for sure. And when the DSM-4 was switching to 5, ASHA's feedback in this category was to add a statement about the language learning environment, and the DSM did take that feedback. So we're similar and agree there as well. And so what I mean by that are things like cultural and linguistic factors. So dialects are not a language disorder, for example, even though certain dialects differ greatly in terms of grammatical markers, sentence structure, vocabulary usage. That is not considered a language disorder. Another example would be children or people who have more than one language exposure or are bilingual. There will be differences in language development that are normal for those populations. So the DSM and speech pathology field really do agree that should be something that's looked at carefully. And then where we differ, the accepted terms that either one of us use. So the DSM is very straightforward. There's one term that you use. Speech pathologists have variability, as I talked about. And even though there's a push to be a little bit more consistent, even within those recommended terms, we categorize it, subcategorize it, and really specify in detail rather than just using one term like language disorder. So we differ a little bit there as well. And we also differ in when to give a language disorder when there's another condition. So in that DSM description, it specifically says that there can't be another disorder explaining it. And for example, with intellectual disability, the DSM says to be careful here and to only give out that diagnosis of a language disorder when it's above and beyond the expected level that you would have language issues with an intellectual disability. So you might expect language levels to be impacted with that diagnosis. And if it's impacted above and beyond that, then that's when DSM would say to give a language disorder diagnosis. However, in the speech pathology field, to us, a language disorder is a language disorder. It does not matter kind of how or why necessarily. And I think that's why there is that push to specify when there is a big diagnosis, that's a main diagnosis rather, that is explaining these language difficulties so that it's a bit more clear. And so that's where that language disorder associated with comes in. But basically, SLPs want to capture, even if a child has an intellectual disability or has autism or has a genetic condition that can cause language issues, it's still a language disorder to us. We want to capture the difficulties that child is having compared to their peers. All right, so the next category in the DSM-5 is speech sound disorder, or the next disorder rather, in the communication disorder category. They describe speech sound disorder as persistent difficulty with speech sound production that interferes with speech intelligibility. It causes limitations in effective communication that interfere with social participation, academic achievement, and occupational performance, and not attributable to other conditions such as cerebral palsy, hearing loss, traumatic brain injury, and so on. And just a note, when we're talking about speech intelligibility, intelligibility is how well they are understood by the listener or can get their message across. So if they have low intelligibility, that means they are difficult to understand. Speech pathologists describe it very similarly and kind of along with the language disorder section as well, we further categorize it or can categorize it into the different types of speech delays and disorders. So these are conditions affecting the ability to produce those individual sounds that we use for language. There are articulation disorders, phonological disorders, and motor speech disorders. And so you might have heard of all of these things, and I'll talk about how we describe them the next couple slides here. Articulation disorders, those are when you're just having difficulty with where your tongue goes for certain sounds. So you might say wabbit for rabbit because you just really haven't learned yet where to put that tongue in your mouth to make that clear sound. Phonological disorders are a little bit different. So these children that have the issues in this area are learning different sound patterns. So they're learning that, for example, front sounds always go before a vowel, or you can only say front sounds of the mouth in words. You can't say the back sound. So they're learning them in patterns, and they depend on the place in the word and whether they're preceded by a vowel or not. So for example, they might say t, d instead of k, g. So front sounds instead of back sounds. Motor speech disorders, there's two main types here. So dysarthria involves a neuromuscular impairment, so right in the muscle of the speech mechanism. So that could be jaw, tongue, lips, palate, larynx, or voice box. Apraxia doesn't have to do with the specific muscles, and it doesn't have to do necessarily with knowing where the tongue goes, like with articulation. It's more about difficulty making a motor plan, because the speech sounds are very involved with motor planning. There's so many small little muscles that we use for speech. So that signal from the brain to the muscles is where that issue is coming from. Okay, so here is how speech pathologists would kind of categorize this. Similar to language disorders, you will see speech sound delay, or you might see speech sound disorder. Several years ago, ASHA did recommend using speech sound disorder as an umbrella term. So that's the one that I prefer to use. You don't always need to specify which specific type of speech sound disorder a child has, and oftentimes they will have characteristics of all three in some cases. So sometimes it's nice just to use that umbrella term of speech sound disorder. But it does have that same implication too of delay versus disorder, but it's formulated or categorized a little bit differently than with language. And there hasn't been as much firm recommendations going forward with this category. But here's what it might look like in a report. So you might see mild, moderate speech sound delay, severe speech delay. You might see articulation delay or phono delay. And then you might see speech sound disorder. And again, if you see speech sound disorder, I would just assume, okay, that's just an umbrella term to identify that they have speech sound difficulties, and it could either be articulation, phonology, or motor speech. So the DSM-5 and the speech pathology field are similar in their definition for sure. And the absence of physiological problems. So ASHA had recommended that actually motor speech disorders, voice disorders, and resonance disorders not be included under speech sound disorders in the DSM-5 because they are physiological problems rather than mental or neurodevelopmental disorders, and the DSM-5 did leave those out. So just being mindful that the communication disorders section of the DSM-5 falls under that neurodevelopmental larger category. Whereas with speech pathology, we don't really organize it that way. We could, but we don't have a manual like that where it's so laid out. We just kind of treat the disorders that we see. Use of an umbrella term, so that's a little bit similar as well. So speech sound disorders, and it's acceptable to use that in our field as well. And where we differ though is again with, like it was with language, we have more variability that's acceptable in our field. You might see articulation delay. You might see speech sound disorder, whereas with DSM, it's very specific. You will see speech sound disorder and the code next to that. The next disorder on the list here is childhood onset fluency disorder stuttering. So this, in the DSM-5, they describe it as disturbances in the normal fluency and time patterning of speech. And they could look like the following issues: sound and syllable repetitions, prolongations, blocking, repetitions, those sorts of things. It causes anxiety about speaking or limitations in effective communication, social participation, or academic performance, and not attributable to another disorder. Speech pathologists organize it in a slightly different way. So we have fluency disorders, and then we have actually two types of fluency disorders: stuttering and cluttering. But overall, it is similar. It's an interruption to the flow of speaking. And yes, people with fluency disorders also frequently experience psychological, emotional, social, and functional impacts. And I just want to take a second to note that the word fluency refers to the smoothness of speaking, and disfluencies refers to those moments where you're disfluent. But there are typical disfluencies in everyday speech that we all have. I'm sure I have a little bit more right now during my presentation, which is kind of a normal. You get more disfluencies, you revise a bit more when you're nervous or excited. It turns into a fluency disorder when you have more than these just typical or normal disfluencies, and different types and different kind of secondary characteristics. Okay, so stuttering is the most common fluency disorder. That's the one most of us are familiar with, and that's the one that's highlighted in the DSM. The types of things you see most often there are repetitions of sound, syllables, words, or phrases, prolongations of a sound, blocks, broken words like pausing within a word, some tension of, the eye, the head, the facial muscles, and some breathing disruptions as well. Cluttering, it's not as common as stuttering, but it is another fluency disorder that we will come across as speech pathologists. This one, it's quite a bit different than stuttering, but it's very difficult to describe unless you've seen it or heard someone speak with it. But basically, they are perceived as having a fast rate of speech or an irregular speech rate. So sometimes there will be short rushes of speech. Sometimes they have language formulation issues. They'll have words that collapse into each other, or they omit parts of words. So sometimes when I get a referral for someone that might end up having cluttering, the referral question is a speech sound disorder query, that I think there's something happening with the speech sounds. I can't understand them. And it turns out to be a fluency disorder or cluttering. Okay, so this is how we would categorize that. So fluency disorders, and that includes both stuttering and cluttering. Oh, and I should mention too, some people do have both. So they might have pure cluttering, but some will have cluttering with also some characteristics of stuttering as well. Okay, so comparing the two, again, the definition is quite similar, but where we differ is that the DSM specifies right in that disorder the age of onset, and we don't. In our speech pathology field, we will just call it fluency disorder or stuttering or cluttering. We don't specify whether it started at what age. It does most often start at the early developmental age for sure, but symptoms might continue and unfold with increasing social communication demands and academic demands at any age. And then, of course, the inclusion of cluttering is missing from the DSM-5, whereas we would include that in our field when describing fluency or diagnosing a fluency disorder. ASHA did recommend during that period of providing feedback from the switch to DSM-5, but it was not included. Okay, the next one on the list here is social pragmatic communication disorder, which the DSM describes as persistent difficulties in the social use of verbal and nonverbal communication. And you will see difficulties using communication for social purposes, being flexible in different situations, understanding and using conversational rules, storytelling, narratives, so things like beginning, middle, and end to your story, and those more abstract parts of language like making inferences, understanding humor and idioms, those kind of non-literal parts of language. And of course, functional limitations and not attributable to other medical conditions. The big one being ASD. So the DSM does specify you need to rule out autism before you can diagnose social pragmatic communication disorder. All right, so this is a copy of the slide we saw previously. And I just bring it up again because I'm going to show where we're going to place kind of social communication disorder in the speech pathology field. So we talked about pragmatic language difficulties as being part of a language disorder, or how we view that. And, you know, something while I was preparing for this presentation too, and just a note that some research authors view pragmatic language as a separate category of social communication. So specifically about the rules that you follow when using language in a conversation. And others kind of use it interchangeably. So, and you'll even see that in the DSM diagnosis, it says social pragmatic communication disorder. So this is a little bit unclear even to me in the field, but most of the time I would say we're using it interchangeably. Pragmatic language and social communication mean very similar things, but in some articles, in some research, you will see it kind of teased out a little bit more. And then something that was also new to me when I was kind of preparing for this presentation, I had done an earlier version of it a few years ago, is that ASHA now has something called social communication disorder, or SCD. I outlined on their resources for SLPs. And it is described very similarly to the DSM diagnosis of social pragmatic communication disorder. So I don't know, we might be seeing this specific term a little bit more in speech pathology. And again, there is a lot of variability in how we describe it. But basically, this is kind of where I put it. So social communication disorder is falling under language delays and disorders. It's a part of that category, but it's also kind of on its own. So we still have pragmatic language down here at the bottom as part of these language disorders. What this kind of means to me in practice is that sometimes we run across kids that might have some pragmatic language difficulties, but that they're not quite meeting criteria for calling it a social communication disorder, either as an SLP would describe it, or specifically what the DSM-5 qualifications are. So there's room for both here, but the main difference between the DSM-5 and between the SLP field is just theoretically, we view it as part of a language disorder. Okay. So I feel like I'm missing a slide here. Maybe not. Okay. So the definition is very similar, as that's kind of been the main similarity between our two fields so far. It's a pattern. And we differ, like I just mentioned, that we don't consider it a separate category. This here again, ASHA actually recommended that they not have a separate category for social pragmatic communication disorder in the DSM-5, but that wasn't one of the recommendations that they took on. Okay. So the last category, or the last disorder here, is unspecified communication disorder. The DSM describes it as symptoms that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, but that it does not meet the full criteria for one of the communication disorders, or that there's insufficient information to make a more specific diagnosis. In speech pathology, as I mentioned before, we don't have a specific category for this with kind of firm guidelines of what to call that or when, but how I kind of relate that or see it being used in our field, sometimes we will just call things a communication disorder. And so what I mean by that is we're not calling it language, we're not calling it speech, we're not calling it fluency, we're just labeling it as communication disorder. And so that I think is the most, or the closest thing that maybe we have to the unspecified communication disorder diagnosis in the DSM. I'm going to give you two examples just from my own experience when I've used it or when I've seen it used. So in young children under 5, I've used or have seen used communication delay or communication disorder. And usually that's used when you can't complete a standardized assessment, or you know that they have issues with language. You might even know they have issues with both receptive and expressive parts of language, but it's really difficult to tease out the severity ratings. Like maybe overall they're severe, but I don't know if it's severe receptive or if it's moderate receptive or that sort of a thing. Then it gives you some flexibility to still call it a communication disorder, but not specify, because sometimes that's hard to do when a child is very low, very severe, or sometimes a child who has both language and speech sound difficulties at a really severe level, it's hard to tease those two out from each other. So if they're dropping off sounds at the ends of words, I'm not going to be able to fully tell their grammar use, because some parts of grammar, like plural S, requires an S at the end of the word. But if their speech sound disorder means they can't make sounds at the end of words, how am I going to know fully the difference between language and speech sound in that case? So sometimes you will see more generic terms used. Oops, my mouse got away from me. Okay. Then another example that I was thinking about was an adolescent that I assessed as part of our Adolescent Day program here at CASA a couple of years ago. And this adolescent had a communication disorder that was very clear to me, but all of the individual difficulties he had wasn't quite enough to kind of label it as maybe a language disorder or maybe a speech sound disorder. So he had very disfluent speech, but it didn't quite seem like stuttering. It didn't quite seem like cluttering, but he definitely had disfluent speech. Some pragmatic language difficulties, some language formulation difficulties, but came out average on the language assessment. But maybe just one subtest was below average in the sentence creation subtest, and maybe some word finding difficulties, but overall vocabulary was average. So just seeing these pieces and specific weaknesses in all these areas, but not quite feeling like you have enough to diagnose each individual area, then that's where I might use that communication disorder and recommending further assessment. So perhaps a really thorough fluency assessment from an SLP who's very specialized in that area might be helpful. So that's kind of what I see as being close to the unspecified communication disorder diagnosis. So between the DSM-5 and the SLP field, we do have some generic terms that we use. That's kind of the similarity there, but it's not a specific category for us. Okay. So we've talked about the DSM-5 communication disorders and how they relate to the SLP field. So hopefully this slide now makes a little bit more sense now that we've talked about it. And just viewing it in a slightly different way, I've got the speech pathology way of thinking about communication disorders up here. All those areas that we kind of talked about: language delays and disorders, speech delays and disorders, and fluency disorders, and how they're subcategorized really specifically in our field. So one of the main differences, if we're thinking about the DSM-5 communication disorders and speech language pathology and how we work with communication disorders, I mentioned this a little bit earlier, is that in the DSM-5, that category of communication disorders falls under neurodevelopmental disorders. In speech pathology, we would still include physiological issues. So I might even add voice and resonance disorders onto this chart, which we didn't talk about. That would still be considered a communication disorder that we assess and treat, if we're not thinking about it specifically as a neurodevelopmental category. And that's also why we see motor speech disorders up here, for example. Okay, so for the last little bit of the presentation, I just want to touch on how speech pathologists assess these communication disorders and how they can, what kind of assessment tools we have to help with the DSM diagnosis of them as well. So we'll start with language disorder. It really depends on the age here. For younger kids, we use language samples, where we write down everything that a child is saying word for word, and we calculate the average length, the mean length of their utterance. Vocabulary checklists also work really well for young kids. Then we have those kind of gold standard formal assessments. The SELF is the main one, and that you will see or hear of used. That's the clinical evaluation of language fundamentals, and the SELF-5 is for 5 and up, and SELF-P3 is for 5 and under. At CASA, we also have the CASL, the Comprehensive Assessment of Spoken Language. And I've also seen the OWLS, the Oral and Written Language Scales, used quite a bit. One thing to note too in this slide that I want to talk about is that language disorder diagnosis is not determined by a specific test score or cutoff, that sort of a thing. So it's not necessary to have, like, they don't have to be severe to be diagnosed as a language disorder, for example, but these tools can still be quite useful because they're quite comprehensive. They go through all different types of language. And the exception to that, I would say, is when funding is involved. And that's a whole other can of worms. But when children are receiving funding from Alberta Education, for example, there are usually requirements or scores or numbers that are required to access that funding. For speech sound disorders, when I talked about the different types of speech sound disorders, articulation, phonology, apraxia, we do have some standardized normed tests that correspond with each of those. So I've got the GFTA and the SPAT-D2 are 2 articulation tests, phonological patterns, and the Kaufman speech praxis test for apraxia. But really, if you're an experienced SLP, all you really need is a good ARTIC test. You can usually get all the information you need for whichever type of speech sound disorder a child has from a good ARTIC test. And then the other thing that's important to add in is an oral mechanism exam. So that is a screen of the structures and functions, the muscles and structures that you use for speech. So taking a look at the lips, the mouth, the jaw, the teeth, the palate, breath support, those sorts of tasks that can be really helpful to differentiate between which type of speech sound disorder they might have. For childhood onset fluency disorder, stuttering, and the DSM, when SLPs are assessing fluency and stuttering, they take a look at the speech fluency, so the frequency, type, and duration of those dysfluencies. And that's how they determine whether, okay, are these normal dysfluencies or is this falling into a disorder range. They often look at speech rate and speech intelligibility and the presence of secondary behaviors. So those are some of those things we talked about earlier, like tension in the face muscles, kind of grimacing, blocks, those types of things. It's really important to take speech samples in a variety of different speaking tasks because fluency and stuttering can improve or worsen in different tasks such as conversations, reading, giving presentations, telling a story, being on stage. All of these sorts of tasks will differ. And it's really important that the environmental and psychological impact is assessed in this area. For social pragmatic communication disorder, this is a tricky area. This is a challenging area to assess. There are formal assessments, and I do use them quite a bit at CASA when a team is querying this diagnosis. So I have access to the social language development test, which takes a look at things like making inferences, social problem solving, conversational rules, and understanding idiom and sarcasm. So a little bit of that abstract part of language. Then I talked about the SLP, which is a comprehensive language assessment. They also have a pragmatics profile, which is an observational checklist and a questionnaire that you can ask a clinician, a teacher, and a parent to gather more information. The CASL-2 is another one of those language assessments. They have a supralinguistic section where they test, similar to social language development tests, they test making inferences, kind of all those abstract areas of language and some conversational pragmatic rules as well. And this is kind of in line with what we were talking about before, that speech pathologists view pragmatic language, social communication as part of language. So that's why several of these main language assessments include some pragmatic language subtests in there. Then there's the test of problem solving. That one is less about social language, but it tests things like making inferences and problem solving, just not in a specific social language context, but that can be really helpful for teasing out abstract language difficulties. And one of the areas, or one of the characteristics that children need to have to get a diagnosis of social pragmatic communication disorder in the DSM is difficulties with discourse and narrative language and storytelling. So there is a test of narrative language that can be helpful to look into this. But that being said, it's helpful to have standardized assessments, but there isn't one single assessment that can determine whether a child has a social pragmatic communication disorder. It's really, really vital in this category that you assess and get contextual information. So what are they actually doing in social situations, not just sitting at a table, looking at a test. It's very important to kind of gather as much information in different environments as you can. Right, and then the last disorder, unspecified communication disorder. We don't have any specific tools for this other than what's already been mentioned. So like I said, if the speech pathologist still believes a child has a communication disorder, they would use their clinical judgment, and they might take pieces or subtests of certain tools that they've used to kind of describe what they're seeing. Right, that's my presentation for today, and I welcome questions and comments, but I believe Dr. Leung is going to pop back on first.
Yes, and so thank you so much, Marie, for this very enlightening and clinically relevant presentation. And I really appreciate how conversant you are in both SLP and DSM-5-TR to help us understand how they map, or I guess don't map on each other. So before we go to the Q&A, I do want to I remind people that, Natasha, do you mind showing the accreditation slide? Yes. So just a reminder that these rounds are accredited by the Royal College of Physicians and Surgeons of Canada and the College of Family Physicians of Canada for live attendance. And for the Royal College, these rounds are accredited for up to 1.25 hours under Section 1. And for the College of Family Physicians, these rounds are certified for up to 1.25 Main Pro Plus credits. And also a reminder for people to complete the evaluation of these rounds. So we have the evaluation link there, or you can use the QR code. The Ground Rounds Committee does look at all of the evaluations, including the comments and the topics suggested, and we really appreciate when rounds participants fill it out. So I'm thinking while people maybe think of their questions, I actually have a couple of questions to start us off with. So, okay, so going back to cluttering, because you had mentioned that fluency a disorder under DSM doesn't really include that. So if, let's say, you do have someone with a cluttering issue, would you just put that under, like, because if especially for psychiatrists and physicians, a lot of times we have to use that coding. So then would you put it under unspecified communication disorder, and then maybe put like in brackets cluttering, or what would you suggest?
That's a great question. I don't think that's necessarily a question for me, actually, because I don't use the DSM. So okay. What would you do? But I feel like it could still go in either. It is a fluency disorder. So if you feel comfortable putting it under the DSM category of fluency disorder stuttering. But I also like that idea of maybe put it in unspecified. Although if we know it's cluttering, then it is specified. So that's a tricky one. And I think that is why ASHA had recommended to either include cluttering along with it, or maybe take out that stuttering part of the DSM. So maybe in the DSM-6, they'll take our recommendations there. But I don't know. What do you think? Or is there anyone in the audience who have come across that?
Well, people are definitely welcome to make comments. Unfortunately, we do not have a, with this webinar format, we don't have that conversant back and forth in a verbal way. So, but if people want to put comments in the Q&A, that would be good. So I'm just actually, I do have the DSM in front of me, and it does say that this category, like the unspecified communication disorder, applies to presentations in which symptoms characteristic of communication disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning predominate, but do not meet full criteria for communication disorder or for any of the disorders in the neurodevelopmental disorders diagnostic class. So to me, I guess one thing is that it like, you know, something like cluttering would have to impact functioning enough that you would even make note of it. And they say it doesn't meet full criteria for any of the other communication disorders in the neurodevelopmental realm, because otherwise I think there'll be like other specified mental disorder, which is even more vague, which I don't see that as being any more helpful. Like I would still want to put it under like a communication disorder. Oh, there is a comment here from Don Young. Thank you for this summary, really easy to follow. My question is about youth with complex learning difficulties, significant behavioral challenges, and communication difficulties. Where can I refer them for an SLP evaluation, particularly for pragmatic language disorder? Do they always need to have a formal autism assessment first? And then there's further comments that there may not be time to wait for an autism assessment, and especially since it may not be warranted. And this includes children in foster care, where communicating and understanding behavioral issues really impacts on stability and placement issues. So yeah, a really good but complex question.
Yeah, great
comment on.
Great questions there. And I'm thinking a few things while I'm was listening to Dr. Leung read your question. So first of all, you don't need a speech pathologist to make any of these diagnoses in the DSM-5. However, I'm simply pointing out that we are very well trained in these areas and can be very useful, helpful team members. And so oftentimes within CASA, where we work in multidisciplinary teams, I will get referrals to help the team kind of rule out or confirm certain diagnoses. But the DSM, like we didn't talk about scope too much, but that is your scope if you're using the DSM to make that diagnosis. If you're needing a little bit more help and support, because like you said, some kids are complex and have difficulties in so many areas, but don't have access to a team, a multidisciplinary team, that can be really difficult and hard to kind of tease out all of the different areas. So for that question about pragmatic language disorder, yeah, I'm thinking a couple things. And again, for the physicians and the psychiatrists and the psychologists in the crowd, again, feel free to comment in the chat. From my perspective and what I've seen, you don't always have to have a formal autism assessment to rule it out. So I've definitely had team discussions or had physicians or psychiatrists kind of say, no, this child does not have autism. That is not a query. We don't need to kind of go in that direction. And then we start looking at social communication pragmatic disorder. So I think you don't necessarily need a referral to the Glenrose and wait that 18 months for it, but you do need someone who has the scope of working with the DSM on your team to make that call. In my experience, that's kind of how I've seen that. So if your team and your physician is sure that that is not autism, but there's something else, then we kind of go straight to talking about, okay, what is it? Some of those complex kids, though, we do want to, or the team does want to have an ADOS or autism assessment first to kind of rule that out. So it's case by case. So I'm sorry, I don't have a straight answer for you, but no, it's not always necessary to have a formal autism assessment first, but sometimes you might want one. And then let me just make sure I answered all the parts of that question. where can I refer them for an SLP evaluation? Okay, so this is a tricky one. You know, within CASA, we only take internal referrals, our speech pathology team. So we don't take external referrals here. If you're specifically looking at autism, we all know the Glenrose is kind of the place to go for that. If you're in a school, working in a school, or the child is attending school, you can always try there first. We do that at CASA as well before we accept referrals. Do they have that service available to them publicly first, and try to access that? So I would check with that child's school, and I would check with sometimes Alberta Health Services works alongside the school. It's changing every year how they kind of divvy up those services. And it also changes based on the political context and elections and funding. So it's a real struggle lately. There's been a lot less funding for speech pathology supports in the school to get those sorts of things. But if you can access a speech pathologist and find out some information about pragmatic language, that can be very helpful, but I understand it's not always available. And then private practice is the other way to go. And that, maybe I'll add that to the chat. So one of the websites to go, I'm just looking it up here. There's a directory to find available speech pathologists in your area to contract out to. All right, I've added that website list in the chat, and that is the Alberta Speech Language Association of Private Practitioners.
Thank you. And actually, while we're talking about, and I know this is not the the purpose of your presentation, but in terms of you know, after you have the assessment and the intervention, so you know, obviously schools, if the, you know, the kid can access. I know sometimes FSCD, or Family Support for Children with Disabilities, and private, but in terms of other than those, are there any other recommendations you would have in terms of like a child to access, you know, more speech and language therapy? Because sometimes it's just rather limited in school in terms of how much speech and language intervention they can receive per year.
Yeah, and again, it's not an easy answer. Those are the main places. So check with the school board, check with Alberta Health Services. You mentioned FSCD, for sure you can check there, and private practice. Those are the main areas.
So I don't see any more you know, questions. Yeah, I'm really glad to you know, have you on board at CASA, and I think we just need more speech and language pathologists in general in you know, children's mental health, because I remember when I was going through my fellowship that you know, up to, like, let's say 30% plus of children with mental health issues actually have a bona fide speech and language disorder or something. And so I think it's probably somewhat even underappreciated, you know, sometimes for our kids. So, but anyways, I guess we're, you know, trying to, you know, address this bit by bit, and your presentation helps us with that. So thank you. Oh, might be another question now. It says, oh, yeah, so I wonder if maybe, I'm not familiar with the foster care clinic. It might be like Dr. Young, who's a pediatrician, maybe at that clinic. It sounds like she would like to chat with you to develop a potential connection with the foster care clinic. I think that might be part of Covenant.
Sure, I'm going to type my email address here for you, and hopefully this will actually show up in the right thread this time. And of course, I would love to connect with you Dawn, and anyone that joined today. If you have questions you think of later, I'd be happy to connect.
Oh yeah, msydney@casaservices.org.
Yeah.
Yes, I see that now. So yeah, that would be really helpful. And it sounds like you're just open to people connecting with you one-on-one, if
Definitely.
desired.
That would be great. And I will say a thank you to you, Dr. Leung, too, because as I understand it, you were one of the big reasons that we got speech pathologists on board at CASA to begin with. And you really pushed to have us involved. So thank you.
You're welcome. Yeah, I push for speech and language and OT, which is actually our Grand Rounds presentation for next month is from an occupational therapist who used to work at CASA. So okay, so thank you all. I think we're about time here. And yeah, have a good rest of your day, and hopefully we'll see you next month.